Ultrasonography in diagnosis and treatment of tennis elbow. Tennis elbow is a common pain syndrome in the PM&R clinics. It is often referred to lateral epicondylitis because of a lateral elbow pain. The cause of a tennis elbow is usually repetitive force on the common extensor tendon around its attachment to lateral humeral epicondyle. Diagnosis of a tennis elbow is usually made clinically without image proof. However, there are actually many different pathologies that can be seen under ultrasound. Anatomically, the common extensor tendon of a lateral elbow is composed of a tendon of three muscles, namely extensor carpi radialis brevis, extensor digitorum, and extensor carpi ulnaris. The extensor carpi radialis brevis contribute most of the deep fiber, with the extensor digitorum making up the superficial part of the tendon. On ultrasound examination, the patient is sitting on a chair with his or her elbow flexed around 90 degrees, being put on the higher chair with a soft pillow under the elbow. The longitudinal scan is performed with putting the transducer on lateral epicondyle and the linear array being parallel to the radius. The normal common extensor tendon appears as an echogenic big-shaped structure. The tendon inserts to the bright curved line which is lateral epicondyle. Radial head can be seen as another bright line caudal to the lateral epicondyle. Under the extensor tendon, lateral collateral ligament between radius and the ulnar bone and the annular ligament around the radial head can be distinguished. The main abnormal sonographic feature of extensor tendon include change of echogenicity, change of thickness, and the change of intratendinous vascularity. In some cases, intratendinous calcification and the spur formation around the lateral epicondyle can be noted. Irregular contour of bony cortex of lateral epicondyle can sometimes be seen. It is thought to be the result of a chronic condition of lateral epicondylitis. In other conditions, peritendinous effusion, partial or full thickness tendon tear, and even underlying ligament rupture can be seen. In this picture, focal hypoechoic area is seen in the common extensor tendon. It is a possible focal tendinosis of the tendon. Color Doppler can be applied in the area of a suspicious pathological change to determine the intratendinous vascularity. Area of hypervascularity was thought to be inflammatory and is highly correlated to the symptom of pain. In condition of hyperemic tendon, ultrasound-guided intratendinous injection with steroid, sclerosing agent, autologous blood, or platelet-rich plasma were proven to be effective in treating refractory tennis elbow. In case of a tendon rupture, severe pain can be the presentation. The integrity of the tendon should be carefully scanned to determine a tendon tear. Any defect of the margin or in the tendon may indicate a tendon rupture. In conclusion, tennis elbow is not simply tendinitis of the extensor tendon. A careful and detailed sonographic examination to extensor tendon, ligament, and the bony structure is extremely helpful to make precise diagnosis and lead to proper treatment for tennis elbow.